Swayam Prabha. Digital India. Educated India.
Hi, I'm Anju Kagal and today I'm going to be telling you about Mycoplasma and chlamydia which cause pneumonia. The common organisms causing lower respiratory tract infections are Streptococcus pneumoniae, Staph aureus, Klebsiella pneumoniae, H. influenzae and M. catarrhalis. But today we are going to be concentrating on this group of organisms, Mycoplasma pneumoniae, chlamydophila pneumoniae, chlamydophila psittaci and chlamydia trachomatis. These organisms are known to cause atypical pneumonias and they are called so because they do not respond to the beta lactam antibiotics. Of this group, we will be restricting ourselves to the first four. I would not be talking about Legionella in this lecture. Let us look at a case study. Here we have Rani, who is a 10-year-old girl who was previously in good health. Rani presented with fever, headache and a dry cough. Her best friend Maya had suffered from similar complaints 2 weeks earlier, and over the next 3 days she found that the fever remained raised, the cough became productive with a clear sputum. On examination, Rani's respiratory rate was raised, her temperature was 38 degrees Celsius, pharynx was inflamed and scattered rhonchi were heard on auscultation. The X-ray of her chest showed patchy infiltrates, WBC count and the differential count were normal, and her gram stain showed scanty neutrophils and no organisms. Her cold agglutination test came positive, indicating that she had a Mycoplasma pneumoniae infection. So, these are the questions which this particular lecture is going to answer. How did Rani acquire the infection? What are the distinguishing features of a Mycoplasma pneumoniae? What is its pathogenicity? What are the complications? And how do we come to a definitive diagnosis? Mycoplasma pneumoniae were first described in 1898 by Nocard and Roux. Initially, they were named pleuropneumonia-like organisms, PPLO. In 1938, Riemann named the disease primary atypical pneumonia because it would not respond to penicillin. In 1944, Eaton grew the organisms in chick embryo and therefore, this organism was called Eaton's agent. Initially, it was believed to be a virus, but in 1961, it was named Mycoplasma. Myco to indicate that it has fungus like branching filaments and plasma because of the plasticity of the shape. So, where do these Mycoplasma exist? They are ubiquitous in nature, found in plants, animals and environmental sources. They are known to contaminate cell lines, and the most important medical ones or the ones which cause disease in humans are Mycoplasma pneumoniae, Mycoplasma hominis and Mycoplasma genitalium, and Mycoplasma pneumoniae is going to be what we will focus on today. Let us look at the morphology of Mycoplasma pneumoniae. These organisms are pleomorphic because they lack a cell wall, but be free to describe what it looks like. It consists of 3-layered cell membrane within which is the cytoplasm. Within this cytoplasm is the DNA. Then you have soluble RNA, and lastly we have got ribosomes. Now, mycoplasma are different from viruses because they possess both DNA and RNA, and they can grow on artificial media. So, they do not need living cells for their survival. They appear as tiny pleomorphic cocci with short rods, short spirals, and sometimes as hollow rings. Their diameter ranges from 0.15 micrometer to 0.3 micrometer. They can pass through bacterial filters. They are fastidious and require cholesterol and sterols for growth, which are provided by serum which we add to the medium. And they demonstrate what we call a gliding motility. Mycoplasma are known to cause tracheobronchitis, and very rarely does the disease progress to become a pneumonia. It usually affects young adults and children. It is known to colonize the upper respiratory tract, and outbreaks occur in crowded areas like schools, colleges, college dormitories, military barracks. It spreads by droplet infection after close contact for a prolonged period. So, as you know, Rani developed the infection almost 2 weeks after her best friend Maya had got the infection. So, because of prolonged contact with her, that is where she must have picked it up. And that is how Rani acquired the infection, from her best friend with whom she was in contact for many days. Coming to the pathogenesis, the organism has a protein attachment factor P1. Now, what happens is that mycoplasma have a predilection for the respiratory tract. So, once they have been inhaled, they will try and go into the respiratory tract, and this, with the help of the P1 attachment factor, they attach to the base of the cilia. Following this, they block the action of the respiratory cilia. The cilia get destroyed and they secrete hydrogen peroxide. This hydrogen peroxide causes damage to the mucosal cells, and mucosal cells ultimately die, and the organism goes deeper into the tissue. The hydrogen peroxide which is produced causes lysis of the red blood cells, and an inflammatory reaction is produced because of cytokines. The clinical syndrome, the incubation period of the disease is 2 to 3 weeks, onset is gradual, fever, chills, malaise, headache, nasal congestion, and a dry non-productive cough are the common features. And this at this stage is tracheobronchitis. As the disease progresses to the alveoli, the sputum becomes more mucoid and blood tinged. Catarrhals appear and the X-ray may show infiltrates. You will find at this stage that the patient can do his routine work, and therefore, the disease is referred to as a walking pneumonia. So, what are the distinguishing features of Mycoplasma pneumonia infection? The most characteristic thing is that although the patient has pneumonia, he can do his routine jobs. This pneumonia is also termed an atypical pneumonia because the patient does not respond to beta lactam antibiotics, as they do not possess a cell wall. The complications of Mycoplasma pneumonia is serious pneumonia, encephalitis, hemolytic anemia, and renal dysfunction. So, these are the complications. Okay, let us move on to the laboratory diagnosis of Mycoplasma pneumoniae. The specimens which are usually collected are throat swabs, sputum and bronchoalveolar lavage. These are the specimens if we want to detect the organism. Microscopy, I will be covering it, is not really very useful in the diagnosis. The organism is gram negative, but better stained by Giemsa stain. But because these organisms are highly pleomorphic, varying from small spherical shapes to larger branching filaments, they can often be missed. In the laboratory diagnosis, to the respiratory secretions we can now add serum when we are going to be conducting immunological tests. So, the various methods of diagnosing would be by culture, by immunological tests where we can detect antibody in the patient's serum or antigen in the patient's respiratory samples, and molecular methods where we will demonstrate the DNA in patients' respiratory secretions. So, let us start with culture. Transport of the respiratory secretions is done in PPLO broth. This is then inoculated in PPLO agar, to which yeast and horse serum has been added. Horse serum is a source of sterols and cholesterol, which facilitates the growth of the organism, and penicillin and thallium acetate are selective agents. PPLO agar is now being replaced by SP4, which is a sugar phosphate medium. It is more complex and already contains fetal bovine serum. Now, whichever medium we were inoculated in, we incubate this at 37 to 39 degrees Celsius in 5 to 10% carbon dioxide for 4 weeks. So, this is a very slow growing organism, and you have to look for its growth under the microscope, because the colonies which are produced are only 10 to 100 micron in size. So, this gives you the reason why the doctor did not send Rani's sample for culture, but instead did a serological test so that he could get a rapid diagnosis. Within 4 weeks, you will see typical fried egg appearance of colonies. They possess a central opaque granular area of growth which extends into the depth of the medium, and this is surrounded by a flat translucent peripheral zone. A better way of observing these colonies is to stain with methylene blue, a procedure which is called the Dine's method. Here you can easily visualize the central area and the peripheral translucent area. Identification of colonies of Mycoplasma pneumoniae is done by the heme adsorption test, tetrazolium reduction test and growth inhibition test. In heme adsorption test, this organism adsorbs guinea pig RBCs on the colony surface. In the tetrazolium reduction test, colorless tetrazolium compound changes the color of the medium to a red color, and therefore, it indicates it is Mycoplasma pneumoniae. And in the growth inhibition test, presence of antisera can inhibit the growth of Mycoplasma pneumoniae. We move on to the serological tests which are used for the diagnosis of Mycoplasma pneumonia. We have the antibody detection tests, in which the non-specific tests include the Streptococcus mg test and the cold agglutination test. Both these tests are heterophile agglutination tests. That is, the antigen which is used is shared between Mycoplasma and the Streptococcus or the human RBCs. We have the specific test, that is the complement fixation test, immunofluorescence test and the ELISA using the P1 antigen. Let us look at the non-specific serological tests. The cold agglutination test is a test in which we take serial dilutions of the patient's serum, to which we add O group erythrocytes. This is then incubated at 4 degrees Celsius. So, that is the cold part of the cold agglutination test, and a titer of 1 in 32 or above is diagnostic of Mycoplasma pneumoniae. The problem with this test is that it is not reliable, positive in only about 50 to 60% of the cases, and cross reacts with Epstein-Barr virus, cytomegalovirus and Klebsiella pneumoniae infections. So, what it means is that antibodies against these organisms may also give a false positive cold agglutination test. The Streptococcus mg test is similar. Patient serum to which Streptococcus mg is added. Agglutination occurs here at 37 degrees Celsius and titers of 1 in 20 or greater than 1 in 20 are diagnostic. Again, the sensitivity and specificity of this test is very poor. In the specific tests, we have the complement fixation test and the ELISA using the P1 antigen, which are nowadays used. They have an acceptable sensitivity and specificity. For complement fixation tests, we have to collect paired sera. And what does paired sera mean? One serum is collected during the acute phase of the illness, and the second one is collected 10 to 14 days from the convalescent sera of the same patient. And in this sample, in these two samples, you must demonstrate a 4-fold rise in titer. The ELISA using P1 antigen is more specific and has now replaced the tedious complement fixation tests. Antigen detection tests, these are more specific, and the two common ones which are used are the direct immunofluorescence test and the capture ELISA assay. In both these tests, the Mycoplasma pneumoniae antigens can be detected directly in the clinical specimen. In the capture ELISA assay, monoclonal antibodies against P1 adhesion antigen are used in the plates, and these will detect the P1 antigen. Molecular tests like the PCR, real time PCR and DNA probes are nowadays being used. However, their use is restricted in reference laboratories. The advantage of the PCR test is that it will detect the presence of the organism even before antibodies have started appearing in the patient's sample. The DNA probes detect M. pneumoniae ribosomal RNA and shows a 90% sensitivity. So, how do we make a definitive diagnosis? Now, let us look at a clinical and laboratory correlation. So, like I said, when the patient presents with fever and malaise and chills, you will find that the maximum or the highest temperature is usually reached in week 3 to 4. The patient also develops a dry persistent cough, where the maximum intensity is again somewhere around about the 3.5 to 4.5 weeks, but it persists sometimes even up to 8 weeks. So, the patient is culture positive from about 1.5 weeks to about 8 weeks, with the maximum being from 3 to 5 weeks. PCR is positive right from the beginning of the infection till almost 8 weeks. Antigen detection is also seen during this period. Coming to the antibody tests, the most specific antibody test is the ELISA test against the P1 antigen. Now, this ELISA test, the antibodies start increasing from about week 2, they peak at about 5 to 6 weeks and then gradually decline till but persist till 9 months. Coming to the cold agglutination test, here again the antibodies will start rising in the second week, peak somewhere in the 3rd to 4th week, but these drop more rapidly by about the 7th week. The complement fixation test shows a rise in antibody titer from again the second week, but the maximum levels are found in week 5 to 7. but these antibodies persist in the serum till almost 12 months. Treatment for Mycoplasma. The first line of treatment for children is macrolides like erythromycin, azithromycin, clarithromycin, and in adults doxycycline, tetracycline and quinolones. Chlamydia. These are obligate intracellular parasites 0.2 to 1 micron in size. Their cell wall is rich in lipopolysaccharide, however, it lacks peptidoglycan. It cannot synthesize its own ATP, and these organisms are not affected by beta-lactam antibiotics. There are 3 main species which can cause pneumonia: Chlamydia pneumoniae, Chlamydia psittaci and Chlamydia trachomatis. Chlamydia trachomatis is actually more famous for causing sexually transmitted diseases as well as trachoma, and so the infections, that is Chlamydia trachomatis pneumonia, is seen in infants who are born to mothers who have the infection in their genital tract. Chlamydia exist in 2 morphological forms. We have the infective elementary body and the reticulate body, which multiplies by binary fission. So, what happens is that the elementary body comes in contact with the cells of the respiratory system. It is ingested by endocytosis. Within this vacuole, it gets converted into the reticulate body, which multiplies, like I told you, by binary fission, and releases multiple elementary bodies which are infectious and will then infect the surrounding cells. Chlamydia pneumoniae, also known as the Taiwan acute respiratory agent or TWAR, from names of the 2 original isolates, TW standing for Taiwan and AR standing for acute respiratory isolate. Transmission of this organism is human to human. There is no known animal reservoir. The diseases caused by it include pharyngitis, bronchitis, atypical pneumonia, and now the latest to this is the coronary artery disease. As far as the clinical presentation is concerned, most patients are asymptomatic. The incubation period of this disease is 1 to 3 weeks, and the symptoms are very often like a viral infection, where you have upper respiratory tract symptoms, rhinitis, laryngitis, pharyngitis or sinusitis with fever. Pneumonia, which occurs, usually does so after 1 to 4 weeks of these initial symptoms. The patient will have a dry cough, scanty sputum, and the cough will persist for weeks to months despite therapy. Along with this, feeling of malaise also persists for a long period of time. A pulse temperature dissociation, that is fever without an elevated pulse, is a common feature of a Chlamydia pneumoniae infection. Somnolence and splenomegaly are additional characteristic features of a Chlamydia pneumoniae infection. The laboratory diagnosis: sample which we collect is sputum. We can demonstrate the presence of pear-shaped inclusions in the cytoplasm. These on Giemsa stain are basophilic. The organism can be isolated in a high containment laboratory in Hep2 cell line. However, they show poor growth. Real-time PCR can demonstrate the presence of these organisms in respiratory secretion. Coming to the immunological tests, antigen detection tests consist of direct immunofluorescent test and the enzyme immunoassay tests. Antibody detection can be done by the complement fixation test, ELISA, or what is more specific for chlamydia pneumoniae is the microimmunofluorescence test, where a single IgM titer of equal to or more than 1 in 16 is diagnostic of the disease. Otherwise, you can also demonstrate a 4-fold rise in IgG titers by the MIF test. Chlamydia psittaci. This is a zoonotic infection. It is a disease of the birds, especially parrots, and the organism is shed in secretions of the eye, nose, mouth, feathers and feces of the infected bird. The organism enters by inhalation of dried feces or any of these dried up secretions. The organism multiplies in the reticuloendothelial system in the liver and spleen, causing focal necrosis and then spreads to the lungs. It is a disease which is commonly seen in poultry workers, pet shop workers, vets and bird collectors. And remember, the infection is only by inhalation and not by consuming the meat of birds. The disease is also referred to as ornithosis to represent other birds, for example, turkeys, which can also harbor these organisms. However, the term psittacosis is still commonly used by most people. The clinical presentation of a chlamydia psittaci pneumoniae. It has an incubation period of 5 to 14 days. The patient will give you history of exposure to bird feces, maybe parrots, maybe turkeys. The disease is mild to severe with an associated systemic illness. In fact, most of the times you will find that the patient presents with a fever of unknown origin, where defervescence is usually slow. The patient would have a non-productive cough, if at all, and chest pain is common, but pleuritic pain is rarely seen. Hoarseness of voice, headache and sinus percussion tenderness is a common feature of chlamydia psittaci infection, which would make you really think that this could be because of psittaci. Auscultatory findings may not be representative of the severity of the pneumonia. An X-ray chest would usually show a consolidation in a single lower lobe, but it can sometimes occur as patchy reticular infiltrates which radiate from the hilum, or a diffuse ground glass appearance and often a miliary pattern. Pleural effusions occur in about 50% of patients and are small and asymptomatic. Laboratory diagnosis: you can isolate the organism from respiratory secretions as well as the blood. However, the procedure is hazardous, difficult and should be done in high containment laboratories. Serology is a better way of diagnosing the disease by demonstrating antibodies in the patient's sera, showing a 4-fold rise by complement fixation test, or by detecting an IgM titer of more than 16 by the microimmunofluorescence test. We now move on to chlamydia trachomatis pneumonia. As I mentioned, this is a disease which occurs in infants born to mothers who harbor the organism in their genitalia. The child may present with nasal obstruction, discharge, cough and tachypnea. Most of these patients are afebrile and only moderately ill. You may auscultate rales with good breath sounds. Conjunctivitis and middle ear abnormalities can be observed in about 50% of the infants. Laboratory diagnosis would include demonstrating the presence of inclusion bodies in the respiratory secretions of the infants, and these bodies are well defined as compared to Chlamydia pneumoniae or Chlamydia psittaci. Eosinophilia is another feature of this disease, and you can demonstrate a high titer of IgM antibodies in the serum of these infants. Treatment in the babies will be with azithromycin and clarithromycin, and what is important is to treat the mother and her sexual partner. So, to summarize, in today's lecture we have discussed atypical pneumonia. Atypical because these organisms do not respond to the beta lactam antibiotics, as they do not possess a cell wall. We have seen that Mycoplasma pneumoniae causes what we call a walking pneumonia. Although the patient has pneumonia, he goes about his daily jobs quite comfortably. The laboratory diagnosis of all these is mainly by serology or by molecular techniques, although culture techniques are possible, but these have to be done in reference laboratories where you have good facilities to prevent transmission of the infection. Treatment is done with macrolide antibiotics, and in the case of Mycoplasma with tetracyclines or fluoroquinolones. So, thank you. I hope you have enjoyed this lecture.